In today's video, we're going over special tests for rotator cuff pathology. So getting an accurate diagnosis for your patients is obviously important. If someone's dealing with rotator cuff related pain, we want to make sure that we're accurately diagnosing that, because good treatment is actually be pretty important in comparison to something like a frozen shoulder. Now in these tests, it's actually important to understand that the sensitivities and specificities are all over the place based on the study that you read, and a lot of times it's awfully poor. The other thing to keep in mind is that sensitivities and specificities are based off a gold standard. For these studies on rotator cuff pathologies, that's going to be in MRIs. The problem with MRI studies of the rotator cuff is that we know there are lots and lots of asymptomatic rotator cuff injuries. So the problem ends up being, when you have pain, it doesn't always mean you have a lot of damage, and if you have a lot of damage, it doesn't always mean that you have pain. So if we're utilizing MRI to give yourself an accurate sensitivity and specificity of a diagnostic test, we know that we're not necessarily going to have a very accurate test, right? I still like and utilize special tests for the rotator cuff for two reasons. One, we want to start to rule in rotator cuff related pathology because we know these tend to do pretty well with physical therapy, and if we're going to get a diagnosis like frozen shoulder, the treatment needs to be a little bit different. The second reason I like to have a special test battery for the rotator cuff is because we can start to try to figure out which cuff tendon is involved. So if I do a bunch of tests for the infraspinatus, and that's painful and pathologic, I may want to choose a bunch of exercises that target the infraspinatus because we want to have a positive adaptation by exercising that tendon. We don't need to do a whole bunch of subscapularis exercises. These next few tests are trying to diagnose pain within some of the structures in the subacromial space. That could be the subacromial bursa, it also could be the biceps tendon, it also could be the supraspinatus tendon. Hawkins Kennedy test, we're going to take the shoulder, flex it up to 90 degrees, flex the elbow to 90 degrees, and then from here internally rotate the shoulder fully. If this brings on the patient's familiar symptoms within the shoulder, that'd be a positive test. Nears test, from here I stabilize the patient's shoulder blade, and I'm going to take the shoulder while stabilizing and maximally flex the shoulder. A positive test would be a reproduction of the patient's familiar pain. You can also try to internally rotate the shoulder while you do this, and that may also reproduce the patient's familiar symptoms. Painful arc test. In this test, we're going to have the patient flip their palms facing outside, and then from here, just raise the arms fully overhead and all the way back down again. Very good. And then relax for 1 second. So if your patient reports that this reproduces their familiar symptoms between 60 and 120 degrees of motion, but above 120 or below 60, it doesn't provoke the normal symptoms, this would be a positive test. These next tests are going to be specific for the supraspinatus tendon. Empty can test, or the Job's test. From here, you're going to take your patient's arm in the scapular plane, raise up to 90 degrees. From here, you internally rotate so the thumb is facing down. And from here, I'm going to try to push down on your arm. Resist that motion, don't let me push you. Push, 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 and then relaxing. A positive test would be a reproduction of the patient's familiar pain or symptoms. FullCan test, we'll take the patient's shoulder. We're going to go up into 90 degrees of scaption. From here, the thumb stays up towards the ceiling. I'm going to apply a downward pressure here. Don't let me push you down. Push, 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 and then relax. If you have a reproduction of your familiar symptoms while we're doing this test, this would be positive. Drop arm sign, we're going to take the patient's shoulder and just go up into 90 degrees of abduction. From here, I'm going to instruct the patient to hold their arm in place and then let go. When I let go, if there's any sort of drop or you're noticing a shrug, so go ahead and shrug for me a little bit, Taylor, then that would be a positive test. This test is useful for diagnosing large, full thickness cuff tears. External rotation lag sign, we're going to elevate the patient's shoulder 20 degrees. From here, we maximally externally rotate the shoulder. And from here, hold your arm in place. Don't move at all when I let go. I'm going to let go of the hand and wrist. And then if we notice the hand lags or drops forward slightly, that's a sign there may be a large, full thickness rotator cuff tear of the infraspinatus. Drop sign, we're going to take the patient's arm, go up into 90 degrees in the scapular plane. From here, 90 degrees at the elbow, end range external rotation. From here, I'm going to let go of your wrist. I want you to stay in place, okay? I let go of the wrist, and if there's any sort of drop or lag, that's a sign there may be a full thickness, large infraspinatus rotator cuff tear. Hornblower sign, take the patient's arm into 90 degrees of scaption. From here, externally rotate slightly. Now push against my resistance, push, 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 and relax. A positive test would be weakness or reproduction of the patient's familiar symptoms. Weakness and external rotation, we're going to start with the patient's elbowed right to the side. From here, we're going to into 20 degrees of internal rotation. From here, push out against me, nice and strong, push, 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 and relax. A positive test would be weakness or reproduction of the patient's familiar symptoms. These next tests are for the subscapularis. Bear hug test, we're going to take the patient's shoulder, kind of come across the body, go ahead and grab onto the opposite side shoulder. From here, you want to make sure that the elbow is level with the shoulder, and then from here, you're going to instruct the patient to have a downward force into their shoulder, all right? If this reproduces the patient's familiar symptoms, that'd be a sign the subscapularis tendon is involved. Belly press test, examiner's going to take the back of their hand, put it on the patient's belly. From here, use your left side hand, and then press into my hand right here, and then relaxing. A positive test will be a reproduction of the patient's familiar symptoms, or you'll notice sometimes patients compensate by utilizing their wrist and flexing into me. Can you show me that real quick? Yep. And the other thing you may find is some folks will cheat by extending the shoulder. Can you show me that one right there? Good? Yeah. So both of those would be positive. Internal rotation lag sign. You're going to instruct the patient to put their hand behind their back. From here, the examiner is going to grab the wrist and the elbow and pull back into end range. From here, I'm going to let go of your hand and wrist. I want to make sure that you don't allow your hand to sink back down again, okay? So I let go of the wrist. And if you're noticing there's a bit of a lag side, so the hand kind of comes in towards the back, that'd be a positive test, indicative of subscapularis tears. Internal rotation liftoff test, we're going to have the patient put their hand behind their back, and from here you want to instruct your patient to pick their hand off the small of their back. So if there's either an inability to do this or a lot of weakness, so you can give them a little bit of resistance while this happens, then that's a sign that there may be a subscapularis tear. So that's it for the rotator cuff test. To summarize, no single one of these tests is very reliable. However, if you have a battery of them, you can start to rule in a given pathology and may rule out another. That is it for this video, but it's not it for the learning. If you guys want to learn about which patients should go on to get surgery for the rotator cuff and who should have conservative management with physical therapy, I'll leave a link in the corner. Click on that and keep on learning.